Now in the corneal disorders, we will discuss the last three types of keratopathies. As previously we discussed the metabolic keratopathies. Now we will discuss the last three types. Keratoconus, neurotrophic keratopathy and exposure keratopathy. So what is keratoconus? Keratoconus, it is the bulging out of cornea due to the corneal stromal thinning. It is the bulging out of the central and paracentral cornea. Okay, the central and paracentral cornea, when they bulge out to the outside due to the thinning of the stroma, this is called keratoconus. Okay, so what are the causes? The etiologies are keratoconus can be primary and it can be secondary. The primary keratoconus, it is 90% idiopathic. We don't know what is the exact cause, okay? And in 10% cases, it is an autosomal dominant. Autosomal dominant alteration and collagen fibers in other genes, okay? So, basically in the collagen fibers, it is a collagen fiber disease, okay? Then we have the secondary keratoconus. Secondary keratoconus can be due to the ocular problems and can be due to the systemic problems. So, the ocular problems are, for example, it can occur with aniridia, it can occur with retinitis pigmentosa, and in 70% cases, the secondary keratoconus occur with allergic conjunctivitis in ocular causes, okay? So, in ocular causes, 70% is due to the allergic conjunctivitis. And the systemic causes of secondary keratoconus include Down syndrome, atopic dermatitis, and collagen fibers disease such as Marfan syndrome, Ehlers-Danlos syndrome. Okay, so these are the causes of primary and secondary keratoconus. Now pathogenesis. How this bulge out pocket of the cornea develops. How? This is because, as I told you, there are the collagen fibers, okay? And as the basic problem is in the collagen fibers, this is the Descemet membrane, okay? So the basic problem is in the collagen fibers. These collagen fibers, they will thin out and they will start disintegration and degeneration. When these collagen fibers, they disintegrate and degenerate, what will happen? Then we have left with a thin cornea, which will bulges out to the outside. This is called, okay, which will bulges out to the outside. This is called keratoconus. Okay, so this is the pathogenesis. Now, how the patient will present to us? The patient will present to us with painless gradual visual loss in the form of myopia and astigmatism, as there is the bulging out of the cornea. So, what will happen when the light rays, so the light rays will not reach to the retina because of the bulges out of cornea. So in astigmatism, we will have two images. We will have two images on the cornea. And myopia, the light is now focused before the retina and it is not reaching even onto the retina. Okay. So the visual deterioration is in the form of myopia and astigmatism. Okay. But remember, there can be a sudden and painful visual loss if there is a phenomena which is called corneal hydrops. What is happening in the corneal hydrops is that there is a sudden fluid rush into this pocket, okay, into this pocket of the keratoconus. There can be the accumulation, the fluid can accumulate in this pocket, okay. When the fluid suddenly rushes into this pocket, what will happen? It is called corneal hydrops and it will cause sudden painful visual loss. Okay. Now, there are some other signs which are important. Okay. When we advise the patient to look downward, when he looks downward, his lower eyelids will bulge out. This is called Monson sign. Okay. So the bulging of the lower eyelids by looking downward is called Monson sign. We will have Monson sign when we do retinoscopy. As there is astigmatism and there are now two images because of the astigmatism, the light is not focusing on the retina. So retinoscopy will give us scissor reflex. Okay, we will have Monson sign. Retinoscopy will give us scissor reflex, and when we take a look through the slit lamp through the eye, then there are other signs. As there will be a bulging cornea, plus there is a ring which is called Fleischer ring. As we discussed previously in the Wilson disease, that the deposition of copper in the descendant membrane is called Kessler-Fleischer ring. But now this is the deposition around this bulges out cornea, around its base, there will be the deposition of iron, which is called this deposition of iron around this base. This base of this bulges out cone, this is called Fleischer rings, okay? And we have Vogel's lines. The slit lamp will also show us the Vogel's lines. Vogel's lines are stress lines. These are stress lines in the cornea. When we apply pressure on the eye globe, okay, these stress lines will disappear. These are called Vogel's lines, okay? So we will have Monson sign, we will have scissor reflex, Fleischer rings and Vogel's lines in the patient of Keratoconus. These are the end myopia and astigmatism, okay? So these are the clinical features. Now how can we treat the condition? How the Keratoconus can be treated? It can be treated by spectacles, okay, by glasses. So we can correct the myopia and astigmatism with glasses. Astigmatism can be treated with rigid contact lenses, and we can also alter this shape can be altered by intakes. What are intakes? Intakes are small plastic material which can be placed in the cornea, okay? We will place these small plastics in the peripheral cornea, okay, and it will reshape the cornea into a normal shape, okay? It will remove this bulge out cornea. These are called intakes, okay? And there is one more procedure which is called collagen cross linking, CXL. In collagen cross linking, what we are doing, we are trying to stop the progression of the disease. What we are doing, we will remove the epithelium, okay? We will remove the epithelium and we will put riboflavin drops. After removing, we will put drops of riboflavin, and on these drops which we have put it on the corneal stroma, we will apply ultraviolet light. And this riboflavin and the application of ultraviolet light will create cross-linking between these collagen fibers, okay? There will be the creation of cross-linking, and so this cross-linking will stop the collagen degeneration and disintegration and will stop the progression of the disease. This is called collagen cross-linking, okay? And the last remedy, as I discussed in every lecture, that the last remedy with us in the corneal disease is keratoplasty. We have to replace the entire cornea, okay? So it can be, the internal corneal transplantation is called penetrating keratoplasty. So it is the last remedy with us. Now this was about the keratoconus. Now we have the neurotrophic keratopathy. Neurotrophic keratopathy, it is the degeneration of corneal epithelium due to denervation, okay? So when there is the denervation of the corneal epithelium, when there is the denervation, there will be the damage to the corneal epithelium. This is called neurotrophic keratopathy. Etiology. Whenever we know that the cornea is supplied by the trigeminal nerve basically, okay? So anything which damages the trigeminal nerve and its ganglion, its branches, it will be causing the neurotrophic keratopathy. So for example, surgical procedure, okay, on trigeminal ganglion or near the trigeminal ganglion. Tumors, for example, the tumor, acoustic neuroma can cause damage to the trigeminal ganglion. The systemic diseases like the diabetes, syphilis and leprosy, these can also damage the trigeminal nerve and its ganglion and can cause the neurotrophic keratopathy, okay? So what is the pathogenesis? How the denervation of the cornea can cause the damage to the epithelium? This is because of multiple reasons. As we know that the trigeminal ganglion, okay, the trigeminal ganglion through its branches, it is supplying the nerve, or it is supplying the cornea, okay. So it is providing the reflex. We know that when there is some irritation, there is the reflex tearing, the reflex lacrimation, which is basically caused by this trigeminal nerve, okay. So the reflex lacrimation and the blinking, when there is some irritation, so we blink the eye. So the reflex lacrimation, the blinking, these are provided by the trigeminal nerve. So when the trigeminal nerve is damaged, it is denervated, there will be no reflex lacrimation, there will be no blinking. So the cornea will be exposed to external environment and can easily be damaged. And the third mechanism of corneal damage, corneal epithelial damage, is that this trigeminal nerve, they also releases a substance which is called neuropeptide. And these neuropeptides, these are necessary for the protein production, for the epithelial growth, and for the normal healing process. Okay, these neuropeptides are necessary. So when there is no trigeminal ganglion, there will be no neuropeptides. So the healing process, the protein synthesis, these processes will be deranged. Okay. So by these three mechanisms, the trigeminal nerves, these are protecting the cornea. So by removing the reflex tearing, the blinking reflex, and by removing the neuropeptides, now the corneal epithelium, it will be damaged. It will be damaged, okay? The corneal epithelium will be damaged. This is the basic pathogenesis of neurotrophic keratopathy. How the patient will present to us? As we know, right, there is no trigeminal ganglion, so the sensation has gone. So there will be the corneal sensitivity will reduce. The corneal sensitivity will be reduced. The reflex tearing will be reduced. The reflex blinking will be finished or reduced, okay? And there will be a painless red eye. So a patient will present to us with painless red eye, decreased lacrimation, decreased blinking, and decreased corneal sensitivity. Okay? These are the clinical features. The treatment. As the tearing is reduced, so we will give artificial tears in the form of ointments and drops. We will give nerve growth factors in order to regenerate the trigeminal ganglion, the trigeminal nerve are its ganglion and branches, okay? So we will give nerve growth factors. And in order to reduce or to prevent damage, we will give anticollagenases in order to prevent the damage to the corneal stroma. We will give anticollagenase. Okay, so these are the treatment options for the neurotrophic keratopathy. The last one we have is the exposure keratopathy. Exposure keratopathy means when the eyelids are not completely closing the eyeball, so the eyeball will be exposed to the external environment and will become dry. This is called exposure keratopathy. When the eyelids, they are not completely closing, so the eyeball will be exposed to the outside environment, and hence due to the outside environment, the cornea will become dry and it will causes keratopathy, which is called exposure keratopathy. Etiology. Why the eyelids are not completely closing? Why they are not closing? This is because when there is damage to the seventh nerve, which is called Bell's palsy. And Bell's palsy, the seven nerves are supplying these muscles. So in Bell's palsy, the eyelids cannot close completely. And ectropion, when the eyelids move away from the eyeball, okay? So in it, the eyelids are not completely closing the eye. And proptosis, in which the eyeball bulges to the outside. In thyroid eye disease, okay? So in these cases, the eyelids are not completely closing in order to close the eyeball, okay? So they are not closing, so there will be the eye is now exposed to the outside environment and is easy to dry and damage, okay? Pathogenesis. Pathogenesis is simple. As there is drying, so due to the drying there will be damage to the cornea and its epithelium, and its all layers can be damaged, okay? So it's the pathogenesis, okay? How the patient will present to us. With exposure keratopathy, the patient will present to us with the symptoms of dry eye syndrome. Okay, what is happening in dry eye syndrome? There will be pain, photophobia, lacrimation, redness, and foreign body sensation. Okay, which in these symptoms are present in every corneal disease, but that depends on the severity and duration of infection. These symptoms can be mild, moderate, or severe. Okay, so there will be punctate epithelial keratopathy will also be present. Okay, the corneal epithelium will initially damage dispersely. So we will have punctate epithelial keratopathy. And now the cornea has dried. So what will happen? The leftover mucus will become desiccated. It will desiccate it and will form mucus strands. Okay, and we will have corneal filaments. As due to the punctate epithelial keratopathy and the mucus strands, they will come together, and these will form like this. Is, for example, if this is the mucus strand, okay, this is the mucus strand, it will be covered by these punctate epithelial erosion cells. Okay, these will be covered by this mucus strand will be covered by these cells, and this combination is called corneal filaments. And with each blinking, these corneal filaments will also rub the cornea and will cause pain. These are called corneal filaments. Okay, so in exposure keratopathy, we will have pain, punctate epithelial keratopathy, we will have mucus strands, corneal filaments, etc. Okay, so these are the clinical feature and presentation of the patient in exposure keratopathy. Treatment. The treatment is we have to give the patient artificial tears. If the eye is dry, so we have to give the artificial tears. But the most important and the most common method which has been used for exposure keratopathy is tarsorrhaphy. Tarsorrhaphy is the suturing of the lower and upper eyelids together at the medial canthal area and the lateral canthal areas. Okay, so we will suture the upper and lower eyelid margins at the medial canthal area and the lateral canthal areas. Okay, and this will reduce the interpalpebral fissure. Okay, and will reduce the drying of the cornea. This is called tarsorrhaphy, and it is the most common and major method for exposure keratopathy. So this was about the keratopathies. I also have prepared notes. I will give you the link in the description. You can go through the notes and can learn more. Thanks for watching the video.